talk about. So make sure you're asking good questions and pick his brain a little, because I know I do that sometimes. It's a little, hey, Dr. T, what do you think of that? So make sure you ask him good questions, he'll answer them for sure.
So
without further ado.
So we got lunch after this, so you can go as long as you want, really. You know.
There's your microphone, and you are set, sir. No problem.
So hello, for those who don't know me, for those who don't, does it work?
Yeah.
Yeah. Okay, hello, good morning. For those who don't know me, I'm Dr. George Touliatos. My nickname is Dr. T, coming from Dr. Testosterone. Now I'm a biopathologist MD. I have my own business in Greece. I cooperate also with a private clinic, and also I work for Balance My Hormones in the UK. I'm associate of Anabolics book 11th edition, and also have my monthly column in Muscular Development magazine for 3 years now, and my weekly show Ask Dr. Testosterone, where I ask and where they ask and answer Q&As regarding everything about harm reduction and replacement therapy in bodybuilding. So I come from a medical field background. My family were all doctors, and my passion, of course, were athletics and bodybuilding, weightlifting. I started lifting from 16. So I come from the bodybuilding community, and I was a competitive bodybuilder that later switched from the body to the mind. So now, as I walk the talk, I write books and articles about fitness and bodybuilding in particular. So I've written 4 books in Greek, 4 in English, that are purchased on Amazon, and another in Italian, translated. And also I've written some articles in websites like Anabolic.org, steroid abuse, and I've been presenting in Generation Iron, RX Muscle, TRT Revolution, Dragon Slayers Media, Superhuman Radio. And what I do is I want to teach people how to avoid doing my mistakes, because I paid the price. So I follow replacement therapy for life because I no longer produce testosterone because of my abuse in steroids. And of course, this is something that you can avoid, but certainly replacement therapy leads to longevity, is a part of anti-aging. The point is you can face many other issues out of steroid abuse linked to the cardiovascular system, the heart, the brain, the liver, the kidneys, the vital organs. So the topic today is the harm reduction in steroids, so how to minimize the stress, and then the replacement therapy in those who retire from bodybuilding, because 100% almost of those who abuse steroids on and off repeatedly for years, they face the anabolic steroid-induced hypergonadism, meaning that when you introduce androgens, then there's a homeostasis and a balance to the system that the system does no longer produce when you administer exogenous hormones. So after repeatedly on and off for years, then the hypothalamus and the testicles do not respond anymore, so you don't produce any more androgens and testosterone, of course, and you face this problem, this hypergonadism. Now, of course, there is the late onset hypergonadism. There's the primary, the secondary from people who age, who abuse narcotics, who have a lot of stress, who are obese, who follow a lousy lifestyle. But the anabolic steroid-induced hypergonadism is a class on its own, and refers to those who abuse androgens and anabolic steroids. Now, regarding the harm reduction, testosterone and its derivatives, the anabolic androgenic steroids, have some deleterious effects in the systems. As I told you, the most critical is the cardiovascular. So having a heart attack out of a heart arrhythmia or ischemia or hypoxia to the myocardium or a stroke can be fatal in the blink of an eye. Unlike a liver cancer or being on dialysis that can give you a poor quality of living, the point is you can prepare yourself to die. So first of all, we need to take care of the cardiovascular system. What are the consequences of using mainly steroids? Because testosterone, frankly, under replacement therapy has only benefits to the heart. And of course, we're talking about optimization. Now, the steroids have a classic side effect to the heart, Number one, heart is a muscle. And actually, heart has 50% of muscle fibers resemble the skeletal striated contractile muscles. The other 50% is myocardial heart tissue. So as we lift weights, and mainly resistance training, not cardiovascular training, as we lift weights, the heart responds and thickens, and mainly thickens the left ventricle, which is the chamber that pumps blood through the aorta to the periphery and the rest of the tissues. So in modern cardiology, as the thickening of the left ventricle happens, the volume of the chamber of the left ventricle minimizes. That means practically that the ejection fraction and the stroke volume of the blood that is pumped to the periphery is less. So this has consequences to the amount of blood and being pumped through the periphery and the oxygen supply, of course. Number two, all tissues and myocardium possesses androgen receptors. That meaning the heart will respond to steroids and become thicker. And if the growth factors come into play, like the growth hormone, the insulin growth factor, or perhaps mechanogrowth factor or cholestatic, then we have the so-called organomegaly, meaning the heart and every organ, of course, but the heart specifically will arouse as a whole, as an organ. And we have the cardiomegaly, okay? So meaning the heart from 300 grams will duplicate to 600 grams, and in some extreme cases of Rich Piana, it was 800 grams. It was so big that it couldn't fit into the mesothorax, meaning between the legs, and it's compressed by the sternum. So mostly people who lift vigorously and build muscle without taking growth factors, and perhaps even without taking steroids, they build a slight LVH, which is the left ventricular hypertrophy. And this with cardiology is measured with an ultrasound in millimeters. So I guess the limit is to have 12 to 30 millimeters. If you have 11, you're fine. Personally, I used to have 13, now I have 12. And I'm trying to regulate this by lowering the intensity and lowering the heavy load of the weights that I lift, and dropping down to 11. Now, an LVH will lead also to higher blood pressure. Another thing is that as steroids are applied, steroids treat anemia, okay, in first place. Now, steroids will meet by kicking EPO. They make more red blood cells, erythrocytes. This is something I spoke yesterday about the potential side effects of replacement therapy. Now, erythrocytosis is a process that happens in the red bone marrow, and by making more red blood cells and erythrocytes, hemoglobin, which is a protein that carries oxygen to the tissues, and myoglobin, of course, to the skeletal muscle, elevates. As a result, also, the percentage of the erythrocytes in the plasma, meaning the hematocrit, also elevates. This practically equals to a thickening in the blood, the viscosity. So blood becomes more viscous. And according to the ranges, a man should have a hemoglobin below 18. Now, if we multiply 3 times the hemoglobin, we get the percentage of the hematocrit. So roughly, until 55% is the limited the range that you can have as a guy, hemoglobin, hematocrit. So 18 hemoglobin and 54, 57 hematocrit. I have to tell you though that hemoglobin is a steady number that does not change. However, hematocrit is affected by hydration. So if we are dehydrated, hematocrit should elevate in a way that the plasma becomes more dense, more concentrated. So you may have a hemoglobin of 17, and hematocrit instead of 51 should be 52, 53, 54. And if you drink extra fluid, it goes down to 51 or even 49 sometimes, and you may trick the labs by overhydrating before CBC and have, for instance, a hemoglobin of 18 and have a hematocrit of 51, for instance. But anyway, what determines erythrocytosis is hemoglobin, not hematocrit. So a hemoglobin should be roughly below 18. Now, what comes into play are the platelets, the thrombocytes. Now, platelets are really important to form a clot. And a preventive way in order to avoid a higher viscosity of the blood with a higher hemoglobin is to deactivate the platelets. We cannot lower their absolute number, but we can deactivate it by taking salicylic acid with aspirin, or for those who have enzymatic deficiency of the GCPD enzyme, that are born with it, they can take instead fish oil, EPA. Now, fish oil and aspirin block the prostaglandins that are inflammatory cytokines that are able to deactivate the platelets. I have to tell you that when I'm taking aspirin progressively, sometimes I have a nosebleed way more easier, and my blood and the bleeding does not stop. Perhaps I need to press to apply pressure in my nose, harder, and perhaps 1 minute more in order to stop. But this is something important in order to avoid clotting. Another way in order to avoid clotting is to improve the blood flow. Now, there is a medication that I'm taking also called Pentoxiphely. Now, Pentoxiphely is a medication that helps with the production of nitric oxide and vasodilation. Now, Pentoxiphely is provided and is, among the indication of its use is to avoid deep venous thrombosis, okay? So it's not a blood thinner, but it improves circulation. And another thing is that if you lower your blood pressure by taking either angiotensin-converting enzyme ACE inhibitors or angiotensin receptor blockers or by calcium channel blockers or perhaps by diuretics, mostly those medications that I referred to in first place, they have this exclusive side effect of anemia. For some people, it's really helpful. So you can take a medication called losartan that has some off-label side effect to lead to anemia. For some people, it's really helpful. So myself, I'll never become anemic. I never had in my life a hematocrit below 45, even before I've touched steroids. So some people are really prone to anemia, and some people, when they have thalassemia also, and some people are really prone to erythrocytosis. So I'm unfortunate because I'm genetically predisposed to have a very sensitive bone marrow, and I need to blood donate every 60 days, unlike other people who were blasting steroids and never had a hematocrit over 50. But anyhow, in order to prevent and avoid erythrocytosis, we can follow the certain steps like overhydration, use aspirin or fish oil, use pentoxiphely, use losartan, and of course, blood donate every 60 days or 90 days. Now it's critical to follow this this window of 60 days to 90 days, which is 2 to 3 months, simply because the lifespan of the erythrocytes is 90 days. Now, if you overdo too much of phlebotomy and blood donation, and actually what differentiates phlebotomy from blood donation is the amount of hemoglobin. So if you're considered as ill and erythrocytotic, and your blood is wasted when your hemoglobin is over 18. So you shouldn't donate sooner than 60 days simply because you have a rebound effect to the bone marrow. So this technical anemia that occurs through the blood donation makes the system to realize that something's going on and it kicks back more erythrocytes. And another thing is to differentiate between erythrocytosis and polycythemia is the number of platelets. So wrongly, many doctors refer to polycythemia if you have elevated hemoglobin with no more platelets. Now, polycythemia vera is a condition determined by elevated also platelets, thrombocytes, and you need, of course, some medications that block the bone marrow, like hydroxyurea, and of course the amount of EPO. Under polycythemia vera, EPO is really low. Anyway, the bodybuilders suffer from the secondary erythrocytosis as a result of the use of androgens. And after they cease the use of androgens, then the hemoglobin drops. Other reasons in order to kick EPO is hypoxia, snoring, sleep apnea, and high altitude, and smoking, of course. Smoking, you introduce CO that leads to hypoxia of the tissues. snoring leads to hypoxia because usually people with thicker necks over 45 centimeters or 19 inches, they tend to snore. Now during snoring, the air goes in a turbulence way, and as you snore, then you wake up choking. And this is actually hypoxic stimulus to the kidneys that kick EPO. In order to avoid now sleep apnea, you can lose weight. You can sleep to the side because sleeping in this way drops the jaw, and usually when the jaw drops, there comes the snoring. Otherwise, apply CPAP mask. And the other way, of course, is to avoid sleep, lose weight, sleep to the side, or apply a CPAP mask. Now, I was telling you about erythrocytosis that increases viscosity and blood pressure. Now, among the side effects of erythrocytosis could be a thrombotic phenomenon, like ischemic stroke in the brain, all right? And we need to monitor the CBC before entering a cycle, and of course, among the indications, the contradictions of the replacement therapy is the elevated hemoglobin. Now, speaking about cardiovascular system, a classic side effect is the dyslipidemia, meaning the reduction of the good cholesterol, HDL, that clears the arteries, and the elevation of the bad cholesterol, the LDL, and the total cholesterol also, that clogs the arteries. And actually, the best scenario is the oxidation of the LDL. Now, this is something that happens because it has to do with an enzyme in the liver, and those lipoprotein fragments, these cholesterol fragments, actually are made in the liver. So, usually, the 17-alkylated steroids, or when you have liver toxicity out of steroid abuse of injectables, the liver is ill, and so under liver disease, there's no good, the making of those molecules is not so proper. So we have low HDL, sometimes single digit, and we have 3-digit LDL. We know that LDL has to be below 100. And of course, the total cholesterol goes sky high. Another thing we need to evaluate is homocysteine, which is a toxic compound that elevates and is linked to deep venous thrombosis and pulmonary embolism. Now, homocysteine is elevated by smoking and by steroids. In order to lower homocysteine, we need to apply B12 cobalamin, folic acid, and trimethylglycine beta. And so there's stacking of supplements. They can help you to lower control single-digit homocysteine below 10 when you're in a cycle, okay? So this is about the cardiovascular system. Now, blood pressure, of course, we need to avoid salt, okay? Steroids, of course, kick aldosterone. Aldosterone retains sodium and water as a result. This is a classic fundamental mechanism that how blood pressure is established. All right, and of course we need to avoid stimulants. Stimulants like clenbuterol, ephedrine, thyroxine, amphetamines, they kick adrenaline, okay, catecholamines, and they provide vasoconstriction, narrowing blood vessels, and this is how blood pressure also is increased. So this is about the cardiovascular system, which is really critical, and it can be fatal in a heartbeat. Now, moving to the other vital organ, which is the liver, I have to tell you that the liver has a really great capacity in order to recover. We have 4 main stages of liver disease. Number 1, we have the pharmaceutical hepatitis, which is meaning transaminase, elevation of ALT, AST, SGOT, SGPT. And occasionally, we have the elevation of the cholestatic enzymes like GGT and alkaline phosphatase. These are accompanied with jaundice, meaning elevation of bilirubin and the yellowish of the eye sclera and of the skin. This is also clinically characterized by itching. So first of all, we have the pharmaceutical hepatitis, and then we have the cholestasis or the jaundice. After this, we move to the bilious hepatis. The architecture of the liver changes. We have blood cysts on the liver. However, until this point, it's reversible. If we stop, if we apply certain compounds I'm going to name later, But after this, we have the hepatoma, or hepatocellular carcinoma, and the only way to cure this is by liver transplant. So, regarding pharmaceutical hepatitis, something really that it's messy with medical doctors, because skeletal muscle, heart muscle, and liver possess the same receptors for ALT, AST, meaning they interact with each other. So if you have somebody who's not experienced, MD, and somebody goes with excessive overtraining, leading to rhabdomyolysis, meaning rupturing of the skeletal muscle, the ALT and AST will elevate because of the overtraining and not because of liver disease. And how do we differentiate these? By the cholestatic enzymes that are low, gamma GGT and ALP. Another thing is that when you have a heart attack, also the liver enzymes elevate ALT, AST. And how do we differentiate from liver disease? By the troponin, which is a protein that also elevates, and also by a fragment of CKMB that elevates also on the heart attack. So when somebody comes either with a heart attack or with rhabdomyolysis, they both show some allegedly liver disease, but I told you how to differentiate these from those certain evaluations. Now, I had myself a digital liver enzyme, but my CK was 5,000. Of course, I was extremely overtrained, and this obviously elevated my liver enzyme. So I had a CT scan, and my liver was all clear. And my gamma GT was low, my ALP was low, so the MD approved that it's nothing to do but just rhabdomyolysis that kicks the liver enzymes, okay, but has nothing to do with hepatic damage. So what are the agents that may give a relief to the stress of the liver? Because seriously, when you use steroids, yes, you have elevated liver enzymes, and mainly those pills, the 17-alkylated, that have been modified in order to sustain the liver metabolism, because whenever a compound comes to the system, the liver has to detox it and break it down. Those pills are so effective and so strong anabolics that they are able to sustain the liver metabolism, so the liver struggles so much in order to break them down unsuccessfully eventually. And there comes the transaminemia. Of course, you may have elevated liver enzymes out of abusing injectables that are not toxic, hypothetically, but of course, the side effects are dose dependent. So what we use mainly are liver detox agents like, number one, the most potent is glutathione, mainly intravenous or intramuscular, because glutathione is broken down in the stomach and is not able to work. So injectable glutathione, I was injecting every day 600 milligrams of glutathione, plus N-acetylcysteine that is able to make more glutathione in the liver. Now, glutathione is really important, and HC are really important in COVID, and those patients who are rushed into the ICU and ventilated have depleted levels of glutathione and NHC. Another classic supplement is the milk thistle, or this limarin that's able, is a major antioxidant, is able to synthesize more glutathione in the liver. And another potent antioxidant is the alpha-lipoic acid. So these are the main agents in order to help the liver detox, okay? And then we have the kidneys. Now the kidneys, actually what they do is excrete all the substances, okay? The kidneys receive blood and make it urine. Now the kidneys also are mainly affected by blood pressure. The kidneys regulate the blood pressure through the renin-angiotensin system. And when you take excessive amount of stimulants, you have elevated blood pressure. Either you abuse steroids that elevate blood pressure, maybe trembolone, testosterone, nandrolone, then the elevated blood pressure hits the glomerulus, which is actually the filter, okay? And you have the hardening of the glomerulus, and you have the so-called focal segmental glomerulosclerosis. In other words, the filter that filters all the compounds does not work properly, and then you have protein in the urine wasted, okay? And this is a bad scenario because you should find traces in the urine. when you find traces, when you find certain amount of protein in the urine, then there's a problem. And usually this is by hardening of the glomerulus. So smoking also elevates blood pressure. Of course, smoking leads to reduction of HDL, thickening of the arteries, okay? And along with plaque formation leads to atherosclerosis. And this may lead either to heart attack or an aneurysm rupture. So the kidneys have to be really well regulated by the blood pressure, and of course to be overhydrated, because this is what they do. They filter and they excrete. So dehydration, certain amounts that are certain compounds that are liver toxic, like non-steroid inflammatory drugs, some antibiotics like aminoglycosides, overloading of creatine monohydrate that metabolizes to creatinine, and creatinine is a marker of the renal metabolism, gives a stress to the kidneys. Usually when we take 5 grams of creatinine, it's no problem. And when we overload of 20 grams for 1 week or do it progressively, then there comes a problem, because creatine will metabolize to creatinine, and of course creatinine has to be up to 1.3, let's say. Now creatinine is affected by BMI. The more muscles you have, out of BMI, not fat of course, the more muscles you have, skeletal muscles. Muscles possess creatine, and actually creatine comes from the Greek word kreas, meaning meat. So more muscles in a big guy means more creatine that will be metabolized to creatinine. So there is a problem with huge guys that have elevated creatinine, even though there's something not goes wrong. So actually guys with a BMI over 30, they have a higher range for creatinine, which is 1.5 actually. Smaller guys with a BMI below 25, they have a range of 1.2. And actually creatinine is really what determines the GFR, the glomerular filtration rate. But actually this is for people who don't lift and who don't follow bodybuilding, because if you have a large BMI, you have a higher creatinine, and the rate and the amount of creatinine is also related to the GFR. So the higher the creatinine, the GFR goes down. So actually what is more reliable to measure, to how to calculate GFR, is collect your urine in bottles in 24 hours, give them to the lab and ask for the clearance of the creatinine in the urine. Okay, this is the most reliable thing. So this applies mainly this formula of the GFR, which is related directly to the creatinine, for people who don't lift mainly, who have a BMI of below 25 and not a high amount of skeletal muscle. So I spoke about the main systems: the cardiovascular, the heart and the brain, the liver, the kidneys. Now we have other organs that be affected, like the prostate. But we said yesterday that bodybuilders, frankly, do not develop prostate cancer even though they have massively androgens. And this myth between the testosterone correlation and the prostate cancer no longer exists, is debunked. And actually, estrogens are also blamed for prostate cancer. Of course, BPH is something normal that happens to people also who don't abuse androgens. But BPH and elevated PSA could be the result also of prostatitis, could be the result of the ejaculation, could be the result of riding the bike because the perineum is suppressing the prostate. So if we take, for instance, antibiotics, then the PSA goes down. If we avoid sex for 72 hours, then the PSA may go down. If we don't ride the bike or the bicycle, we don't do spinning, for instance, then the PSA may